And only say those, that you know to be true and that you can answer to. But if your answer is always, I have no idea, you have to wait and talk to your doctor, it's going to be a really not good relationship. Okay? So if you're new and you really have no idea how to answer those questions, how would you adjust to that? Go up the chain of command. Ask for your preceptor, ask for your charge nurse, etc. Ask them to help you answer the question. Again, don't make stuff up. Your patients know when you're making stuff up and when you're lying to them. When you start cutting their eyes around, like, people pick up on that sort of thing. Not everybody, but when the nurse and the doctor give the nurse-doctor look, which is sort of similar to the wife look you get, or your husband look, it's like, you're kind of like, oh there, oh there. People see those things, and they lose all trust in you, They think you're telling secrets. Well, in fact, you might be. Transparency is really important for establishing therapeutic relationships. And some people are really good at that because they're good at telling the truth, and other people are really good at telling lies. It just depends on which one you are. But try to be one good at telling the truth. So we want to minimize the number of vag exams in order to minimize what? Infection. Right. And we've already talked about how to monitor the mom for an infection. How would we know if our fetus might be experiencing infection?
Heart rate,
Tachycardia, probably. Probably tachycardia would give us a clue. If we had a mom whose membranes are ruptured and she's been in labor a long time, the fetus becomes tachycardic, it's going to be one of the things we're going to be thinking of, definitely, for sure. Blah, blah, blah. Okay, questions about that? Okay, preterm and premature rupture of the membranes. These are different. In the clinical setting, sometimes I see that they're used interchangeably. They are not the same. They are different. PROM and PPROM mean something different. PROM means premature rupture of the membranes. These are membranes that rupture prior to the onset of labor. And that's all that means. Membranes rupture prior to the onset of labor. If we have a woman who is 38 to 42 weeks and she has PROM, so her membranes have ruptured but she's not in labor, what would you assume might be happening in her future? Yes, we'll induce her because she needs to deliver and she's term, right? If she's not term, so she's between, how many weeks would preterm be? Between 20 and the end of the 37th week, she's preterm. That's what PPROM is. That's preterm, premature rupture of the membranes. So her membranes have ruptured, and she's somewhere in the preterm period. So that's different, right? Because we want to incubate in the uterus until when? Until it proves itself to not be a good incubator, okay? So we're going to look at some of the complications and the management of that. So, well, the big complication of either one of these is what? Infection. Right. Now, here's what determines how you're going to manage this person, how we can treat them, and what we're going to be doing. If this person, regardless of their gestational age, their membranes rupture and they show signs of infection, they get an immediate delivery. It doesn't matter if they're 24 and a half weeks, 26 weeks, 37 weeks, it doesn't matter. When they appear to be infected, they get delivered. And we've already discussed how we would know, right? Mom has foul discharge, tender uterus, vital signs that are reflective of an infection. What about labs? What lab would we see? White blood cells above what level?
25,000.
Above normal. Above normal. Let's just say above normal. What's normal? 5 to 10,000. So if it's 11, we're probably not too alarmed, right? But if it's elevated. Does your book give a specific number like 25?
Yeah, it says 25 is actually okay for a pregnant woman. We wouldn't get alarmed until it goes above 25.
Part of that is true, but part of it is what did it look like the last time we checked it.
Okay.
You know what I'm saying?
Okay.
Like was it 11 and now today it's 25?
Okay.
That might not be okay.
Okay.
So yes and no.
Okay.
But anyway, when the mom looks infected or the fetus looks like they're infected, we deliver. That's the only difference. Otherwise, we're gonna do what I call, for the non-infected person, we're just gonna sit on them. If they're term, you're probably just gonna go ahead and deliver them as well. There's no reason to sit on them. But if they're PPROM, we'd like for them to incubate in uterus until it's no longer a good spot. And we'll know it's not a good spot when they both have signs, one or both have signs of infection. So in the meantime, you can do hospital or home care. The home care comes in when the membrane's ruptured, but they seal back over, and that's possible. So they can have a small tear, a little leak, and then it lasts several hours, a day or two, and then it stops, and they have no more leakage. And if they have no signs of infection and no leakage, then they can go home and continue to be on, alert for these things we're going to teach them. If they're not stopping leaking, and it just continues and continues and continues, they're going to be hospitalized until when? Until they deliver, yes. And St. Joe's, if you're at St. Joe's, they have a pretty big perinatal unit there, yes, so you usually see quite a few of these people. If you have one, build it and they will come. The other hospitals don't have huge perinatal units. Just saying. And they build it and they don't come. Go figure. Okay, so avoid vaginal intercourse and breast stimulation. If they're PPROM, you don't want anything to stimulate their breast because that can stimulate the release of oxytocin, right? From the pituitary. Also, usually instead of avoid vaginal intercourse, the easiest thing to say is don't put anything in the vagina. Because they might want to put a pad, a tampon in there just to stop leaking. They don't know what you know, okay? So nothing in the vagina includes for medicinal or whatever purposes. And then we will monitor them for signs and symptoms. If they've gone home, we'll continue telling them what signs and symptoms to monitor for and when to call. That'll be part of our discharge teaching. Activity restrictions. Once the membranes have been ruptured, usually the mom will remain on bed rest and sometimes given bathroom privileges only and sometimes not. But that's because there's a high risk now of cord prolapse. Okay, so once the membranes are ruptured, and if they have not sealed over, the activity is usually going to be restricted to bed. Now, what if she's 24 weeks, 26 weeks? Like, how long are we going to keep her in the bed?
All the time.
Until she delivers. Now, what kind of patient does that get you? She's real sweet and worried, and she loves you. You have saved her life and the life of her baby. And then, a couple of weeks later, you guys are still hanging out all day, every day. Like you and nobody else. Or, she might like one person. Anybody who's been in labor and delivery at Florida Hospital, there's a tech there, but she's been doing a lot of the front desk stuff. Her name's Ruthie, and she's really sweet. And there have been a few patients who attach to her like, barnacles. They're like, I want Ruthie. There'll be like a sign on the door, only Ruthie can come in. Or you'll see a sign on this patient's door, no entry between these times, no breakfast before this time. And you're like, what? Do they think they like own the place around here? They like bossing us around? Well, what's happening?
They live there.
They live there and they lost control of the rest of their life. You stuck them in the bed, they can't go to work, they can't take care of their kids, they can't do anything else in their normal life. But by golly, they can say who comes in and what time they're going to eat their breakfast. And pretty much that's what you get. Now that can transfer and translate to any other hospitalization as well, because let's face it, when you're hospitalized, you do lose control. We're in there and out of there, we're in your business, right? Even when you don't want to. Help you to the bathroom, wipe your bum. They're like, oh, no, no. Well, you're like, well, it's not like I really want to, but if I don't, I know it's not going to happen. And I know skin integrity, this is the problem. But how many people say, oh, could you please wipe my bottom for me? You'd be surprised. Okay, so I haven't done that a lot lately. But I'm thinking most, with it people, nobody wants that, right? So, you do it for them, but they've lost control. So it's a little stressful.
My labor patient last Friday, and I get up to go to the bathroom, and I'm like, you just use the bed again, she's like, I think I can hold it.
She want to use the bed there. Okay. Now, antibiotics, I can't remember if your book says to give prophylactic antibiotics, for PPROM, but in reality, that's what happens, prophylactically, so they'll give them before they get infected. But I think your book might say you don't, but whatever. Corticosteroids, why will that help the mom? That's right, Haley, that was a trick question. It won't help the mom. In fact, it might make her blood sugar go higher, right? So it won't help her, but it may help the fetus if she falls between those periods of gestation that are okay for accelerated fetal lung development. Okay, so if we have PPROM, means premature, right? So we're concerned about a premature delivery. So let's talk about preterm labor. These are the signs and symptoms of preterm labor, and they are on a page in your book.
647.
What's it? 647. Memorize those. I can read them to you, but I don't think there's anything I wanted to add unless I added here in parentheses. I'm not sure that they have that. But these are signs and symptoms of preterm labor. Notice they're not all the same. It's like nobody says, I'm in labor because I'm having contractions every 5 minutes. That's not a question of preterm labor. That's like you're in labor. But there are other signs and symptoms that we are responsible for observing for, monitoring for, and most importantly, teaching our patients about. This is what you might feel like if you're going to have preterm labor. So these are reportable signs and symptoms. Okay? Everybody mark on there? Somebody please tell, who's not here? Simone. Because I'm going to put a question on here too. So she's just out of luck, huh? Okay, so how do we know if somebody's in preterm labor? I think I mentioned before it's a little unfair to have our patients know exactly if they are, because it may take us several lab tests, examinations, hours of monitoring these things before we can determine if they are. Because if it's obvious, it's obvious. But if it's not always obvious. So some things that might be predisposed or predict preterm labor is certainly if they've had preterm labor before. So they especially need to know. Cervical length can predict preterm labor. So this is not a good picture. Well, this is a picture of tunneling, actually. But you remember, for effacement, the cervix thins out, right? Look on your board when you're in labor and delivery or wherever you are. If you have patients who are being in perinatal floor monitored for preterm labor, look at the length of their cervix. And they'll be monitoring it, measuring it usually in millimeters. So anything less than 1.5 millimeters, okay? 1.5 centimeters is considered short. It's short. And some of these patients in preterm labor may have a cervix that's already like 5 millimeters. It's teeny tiny, okay, real thin already. They're at real high risk of preterm labor. And then it does something funny, and again, this is not the greatest picture. When we look at their cervix or feel their cervix for dilatation, this is what we're feeling. What kind of dilatation are we feeling there? Nothing. This is not open, correct? Even this is not open. We're feeling right across there, it's not open. But what we can see on ultrasound is if there's tunneling. So this is a transvaginal ultrasound because we want what's down in the pelvis, okay, which is your cervix. And so ultrasound, and with the lights off you can see it a little bit better, but this is the drawing of it. This is actually what we might see happening to the cervix. We don't see it on the outside, but it is dilating on the inside or tunneling, okay? Funneling. Funneling, 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 and funneling. This look like a funnel? See there? Yeah. So cervical length, anything less than 1.5 centimeters is shrinking. Okay? So that's an indicator that preterm labor is possible. So these are the things that we're going to measure here. The cervical length and the fetal fibronectin. So to ask somebody at home to do this is not good. But what's the ultimate gold standard of whether this person's in real labor or not? Cervical changes, right, meaning effacement and dilatation that's changing. So fetal fibronectin is a test that we can do with a swab, and we put it into the posterior fornix. So if this is the vagina, here's the posterior area. So we just take this little swab, stick it under the bottom of the cervix, send it to the lab, and within an hour you'll get your result back. And this is a result that its greatest value comes from its negativeness. So if it is negative, a fetal fibronectin that's negative, the research shows, and every company is a little bit different, but it's about 99% shows that with not now are you in labor, and nor will be that patient in labor for 7 days. Now, I don't think they just chose 7 days. I'm sure the research did follow up with the patients, and 99% of the time, if it's negative, they are not in labor for 7 days. So when you get that kind of result, it helps us to know, oh, well, we can just give them some fluids maybe, give them 1 shot of terbutaline maybe, and they'll go on their way. Because they're not really in labor. Their uterus is irritable. Check them for a bladder infection, but they're not in labor. So fetal fibronectin, it comes from the fetal membranes, and it's excreted in the urine of the fetus and then picked up in the cervical mucus that's coming out. So very easy test to do and worth a lot. Now if it comes back positive, it's still a pretty good indication. It's a good test, but it's not 99%. It's usually about 95% that yes, they are in labor or are very high risk to going into labor in the next 7 days. Okay? But it's best when it's negative. Certain infections can predispose women to having preterm labor. Oh my God, the one that we treat, not an STI. Oh, I know, it has a fishy odor. Bacterial vaginosis. Who said that? Thank you, thank you. Bacterial vaginosis is related to preterm labor, as are some other infections as well. But you don't have to know them specifically. I mean, I should. So, we have preterm labor. This is how we can determine it. This is how we can know if they're at risk for getting it. This is what we can do about it. This is an acronym for the medications that we can use that are for It's Not My Time. It's Not My Time. So, indomethacin, nifedipine, magsulfate, and terbutaline. Not necessarily in exact order of which these will be used in, but they all work a little bit differently. So for us in our care plan for our patient with preterm labor, we need to identify and treat any infections like bacterial vaginosis. Hydrate, because a woman who's pregnant and dehydrated, her uterus can be irritable. So hydrate with IV fluid. Sometimes that's all it takes to stop the uterine contraction at all. Limit the activity. This is a very controversial, yet we usually do it kind of thing. There's no real evidence that shows if you, let's quote unquote, take to your bed, you're going to be able to stop preterm labor. It's not going to stop that. If you're in the middle of having a spontaneous abortion, taken to your bed is not going to stop it from happening most likely. However, it does erase and maybe prevent any guilty feelings on the part of the mother, letting her know that she's done everything she could. Because when these things happen, that's what usually women start to say, oh, I knew we shouldn't have had intercourse. Oh, I always play volleyball, but I knew I shouldn't have done that now. That's what caused this. Very rarely is that what causes this, okay? But by telling them to limit their activity, sometimes it can help their minds, if nothing else. And then, these are those tocolytics. These 4 medications are the tocolytics that I mentioned that we gave. What were we giving tocolytics for before? Under what condition?
For the contraction.
External version, right? And I said, just remember, a tocolytic is something that relaxes the uterine muscle, okay? And that's what it is. These are medications that relax the uterine muscle and stop preterm labor, okay? Now, there are 4 listed here. Corticosteroids are on the bottom because that's still on our care plan, and that again is to accelerate as long as it's given within the correct parameters, it's given to accelerate surfactant development for the fetus. These are the 4 tocolytics that we commonly see. We are probably going to see less and less of magsulfate. Magsulfate is like the Uzi, like the AK-47 of these medications. It's like the biggest gun in our arsenal. and we use it sometimes. But what we're finding is, in fact, it's really not any more helpful than a placebo. And it has horrendous side effects. So we're using that less and less. Now, don't get confused when you listen to the lecture on preeclampsia, because magnesium sulfate prevents seizures in preeclampsia, and it does a very good job. So in OB, we're still using magnesium sulfate for that, but using mag sulfate for stopping preterm labor is pretty much beginning to go by the wayside. So our Uzi here, the mag sulfate, is maybe the first drug of choice. It may be never. So I can't tell you which one is going to be first, because it's going to have something to do with where is the patient in terms of preterm labor, what is the knowledge, comfort level of the healthcare provider, what do they usually use and how does it work, and how do they feel about, especially in this case, mag sulfate not being much more effective than a placebo. There was an article a few years ago that was published in JAMA, or ACOG or somebody, I don't know, somebody published it. And it was a comparison study of complications for mom and newborns for moms who were treated with magnesium sulfate for preterm labor and moms who were treated with nifedipine, okay, which is a procardia or calcium antagonist. And the results were that mag sulfate did not stop preterm labor any more than nifedipine. This is a large study with hundreds, if not thousands, of women in it. However, the women and the newborns who had been treated with magnesium sulfate usually ended up in the intensive care with respiratory depression, fluid overload, very complicated, serious events. The number one reported side effect for those women treated for with nifedipine was a headache. Headache, fluid overload, respiratory depression for the newborn, headache for the mom. I mean, if the treatment outcomes are no different, which one would you choose? Well, you choose the one with the fewer complications, which is nifedipine. So that has caused the demise of magnesium sulfate. But remember, I told you, sometimes healthcare providers go to the conference and they get the certificate, but they don't really go to the lectures. So they keep using old news, okay? In big cities, California, New York, they're not using mag sulfate for preterm labor. Not using it, pretty much. Here, we still got some stragglers. Okay? Mag sulfate, regardless, and I can't remember if I'm pretty sure I told you this on the other video, regardless of what you use it for, so for preterm labor or preeclampsia, we still have the same criteria of being able to continue it. Magnesium sulfate is a muscle relaxant, okay? Now it may also lower blood pressure a little, but as you'll hear in my other video, if you have blood pressure, hypertension, mag sulfate is not the treatment for that. It's the treatment to keep you from seizing if you have preeclampsia. In this case, it's to keep your uterus relaxed. It's a muscle relaxant. So there are some important muscles you don't want to over-relax, and those are those that cause you to breathe, okay? So we need to keep track of the breathing. So I could say that you might memorize these, but I could say every patient that you ever encountered or will encounter should all be breathing 12 breaths a minute or more, right? 12 is a pretty low number, okay? So everybody should be breathing 12. It's probably what you've heard before. And all of our clients, adults or, middle pediatrics and up, should have 30 mLs of output per hour. That's a minimum, right? That shouldn't go down at all unless it's for newborns or whatever. And also in this case, because it's a muscle relaxant, we make sure that they still have deep tendon reflexes. Because it's a muscle relaxant, it can relax the reflexes. Again, the reflex to breathe and the reflex to swallow. And it's also a muscle relaxant. And what's your tongue made out of? It's a muscle. And then when it relaxes, they talk like that. Because they can't really use their tongue to talk, so they talk at their like developmentally delayed, let's say. But it relaxes all the muscles. Of course, the target muscle that we're looking for is the uterus. Now, what is Mag-Sulfate? I think I've mentioned to you before, is a powerful medication, and it can relax muscles so much that, you know, you stop breathing. And I told you about the case where the patient got 10 times too much, and even though she was administered the antidote to Mag-Sulfate, she was not able to be resuscitated. So, what is the antidote to Mag-Sulfate? Calcium gluconate. Yes. And it's very important to have on hand. Now, these other three medications are used by some practitioners and some not. Calcium antagonist Procardia or nifedipine, it causes also relaxation of smooth muscle tissue. What we're usually seeing it in is it's relaxing the muscle lining of blood vessels in order to do what? Procardia, nifedipine relaxes the blood vessels and causes blood pressure to go down. Because one of the causes of hypertension is resistance. Okay, so if there's a lot of resistance to pushing it out because it's restricted, if we relax the vessel, it takes that away, and now the blood pressure can go down. That's what we're used to seeing. But in this case, we want it to relax the uterus. But that's why they get a headache as their side effect, because it relaxes their blood vessels, and sort of like a migraine, it's, you know, too much blood and gives you a headache. So that's a possibility. Prostaglandin synthase inhibitors such as Indocin or indomethacin can be used, but not very much. I'm going to put you on the spot, Cornelius. You had a baby in the NICU, and that baby had been treated with indomethacin, or Indocin, for a condition. You remember what it was?
Are you talking about the BB whatever?
Sasha? So say that whole thing. Patent ductus arteriosus. Remember your baby had patent ductus arteriosus? As a newborn, had been given Indocin because it will actually cause constriction and cut that off. It'll close up that PDA. It can do that as a fetus. As a newborn, they don't need their ductus arteriosus, but as a fetus they do. So you don't see that medication used as much. And then beta-androgenic drugs are also smooth muscle relaxers. Terbutaline or breathine is the drug that's usually used. Have you seen this drug in use in any other area? COPD, asthma, yes, because it dilates the bronchioles, which are also smooth muscle. Okay? So we can use it here also. However, over a long period of time, terbutaline, and it has been in the past for preterm labor, been used for days, maybe even weeks as an injection for mom, a subcutaneous injection, can cause tachycardia because it causes tachycardia in everyone, no matter what you use it for. If you use it for COPD or in specific asthma or for preterm labor, mom gets tachycardia, okay? Tachycardia over a long period of time can cause heart failure, irreparable heart failure. So mom has heart failure and does not survive